Alrighty, back into it. So now that Dr. Abbasi has images he likes, as you can see, this patient had a previous L1 all the way down to S1 fusion. Now we're going to do a couple levels about that. You can see in the MRI, patient has some discitis, some degenerative disc. If you have any more questions about the indication, I'm sure Dr. Abbasi would be happy to join after and discuss it. Dr. Abbasi is doing some of his markings now, I believe. Wait till we get a picture. So the first marking Dr. Abbasi is going to make is in the AP view. He's going to draw a midline, so right over the spinous processes. Once he's done that, he's going to draw the trajectory of the disc for the level that he wants to approach. Then the third marking he's going to make is going to be in the lateral view. This one's a little counterintuitive for some people. He's basically going to put the tip of the wire roughly where he wants his cage to be. He's going to mark that off. He's going to pinch the distance between that line and what he calls the apex or the dome of the patient's back. Not to get too much into the details, but what he's trying to do is grab an equal distance, transfer that distance to the midline, and with two equal distance lines, it'll give him a window that is approximately 45 degrees consistently. That's where he gets the approach for his cage. Since this one's thoracic, he will be making a slight modification to account for the thoracic anatomy. The incision for this one will be less lateral and closer to the midline than usual, than you would in a usual lumbar case. Dr. Abbasi looks like he's speaking with his PA, Dominic. Dr. Abbasi has done a couple dozen of these. He's actually working on writing a paper, which is what Dominic is doing some documentation for on this specific approach, the MIS OTIF, OTIF. Looks like we must have punctured a glove. Dr. Abbasi's got a new one ready to go. And now we'll get back to business. Looks like he's, positioning the spinal needle. He usually try and find his approach for his Jamshidi, try and find the pedicle first with the spinal needle. Then he'll go in later, make his incision, and pop his Jamshidi in. Dr. Abbasi is going to start with the Jamshidi. Main reason being that the biologic he uses is tricalcium phosphate-based product. Just tricalcium phosphate, hydroxyapatite, and a little bit of collagen. He mixes that with bone marrow that he's going to be pulling from his Jamshidi here. Mix it on the back table. He uses that to pack the disc space, to pack his cage, and then actually use it to pack the facets later for our posterolateral fusion. Again, for those joining, I ask that you keep your microphones muted just so we can keep the air clear. If you have any questions, please just continue to use the chat feature. I hope I gave enough of a brief overview. I'm not exactly sure what you want. If you have any specific questions to discuss about this case, please just send it my way. I'm happy to answer it, or refer it to Dr. Abbasi when he joins. Dr. Abbasi going with his Jamshidi here. It can be a little bit different for the thoracic anatomy, but generally with this approach, he's trying to pass the medial border of the pedicle around the same time he enters the vertebral body and the lateral. So just about as you see here. Dr. Abbasi using neuromonitoring. What he's doing there is attaching the probe to the Jamshidi itself, stimming up to 35 milliamps. If it's tech in the corner, you can see there, it tells him it's good. I'll go ahead and put the K-wire in to save the trajectory. And we'll use that for our cannulated perk screws later. Here you can see Dr. Abbasi just pulled off a syringe of bone marrow. That's the bone marrow he's going to use on the back to soak his graft. Something else to see Dr. Abbasi do with his bayonets is you'll see he has his tech lay out a set of Raytech sponges. He uses those just to plug up the hole and try and control any bleeding that there might be. Okay. Looks like we're going to make another approach for the T11 here. Get our guide wire in, maybe grab some more bone marrow. Dr. Abbasi generally likes to only pull about 5 to 7 cc's of bone marrow out of any individual vertebral body. He's looked at it under a microscope before and found that once you get past that, it kind of becomes diluted. It's mostly just blood. So to get that stem cell rich, those mesenchymal stem cells, usually tries to keep it to 5 to 7 cc's per vertebral body. You see him making the same approach in his two views there. So trying to enter the posterior border of the vertebral body around the same time he passes the medial border of the pedicle. Once he's found a good position there, he'll do the same thing. He'll stimulate with his probe up to 35 milliamps. If he gets a good signal or something close to that 35 milliamps, he'll accept it. You see him pulling out the inner part of the Jamshidi needle. I assume he'll spin on his Luer lock syringe. Yep, there he goes, asking for it from the back table. He'll pull that back. Something he'll do sometimes to save time, if it's not coming out very fast, allows him to work on other things, is he'll pull the plunger back, and he'll actually click it with a coker, so it's held back. And that allows him to work on other things while the bone marrow gets soaked up. Okay, now we've got our second K-wire in place. Again, grabbing the Raytex sponge, poking it in with the bayonet to help control any bleeding. And it looks like now we're going over towards the, yep, he's grabbing his probe. Now we're going in for the inner body portion. So this is the actual OTIF, oblique thoracic inner body fusion approach. It's going to be similar to an OLIF. Usually it ends up being a bit steeper because of the anatomy, and your incision ends up being a little closer to midline rather than lateral like you would have in the OLIF approach in the lumbar region. But same idea. He's trying to get into Camden's triangle, trying to find a space, trying to find that junction of the transverse process, superior articular process, and the exiting nerve root. And you'll see here, that's a perfect view in the lateral. He'll actually start caudal to the disc space of interest. This helps him do two things. One, it gives him some type of tactile feedback. He's hitting that bony structure below it, and then he'll use that to slide into Camden's rather than trying to freehand it. The other advantage that has versus trying to freehand, go right for the middle of Camden's, is that he's staying medial and inferior to the nerve root. So there's less chance that you'll poke us, less chance that you'll have any post-op nerve root irritation. So it looks like he liked it there. So he's dropping down the outer metal sheath that comes in the probe. That sheath is going to save his trajectory. Now that we've confirmed we have a safe trajectory, he's going to put a wire through there, and then that wire is going to pass the first of our effectively discectomy instruments. Once that wire is in place and he's happy with his position, he's going to control the wire, pull that sheath out. Wait for him to take a new picture here so I can, yep, perfect. And then we're going to go in with a dilator. So this is an 8mm dilator, cannulated. Obviously, this is going to be our first entry into the disc space. He'll usually pass it down. As soon as he kind of gets on the capsule, that's when you'll see him wrap the wire over the top and you start smacking the dilator in. There's a little bit of dealer's choice based on how far you want to go with the dilator. I've seen Dr. Avicenna and other surgeons just be happy to go to the midline on some cases. Sometimes you'll actually see them try and go all the way to the other side and maybe bust up an osteophyte. So it's really whatever you want to accomplish with it. And you really have a lot of control of the instrument still once you've actually entered into Camden's. So you can see him straightening out, making sure he's in the same trajectory as the disc. Helped both by the imaging and the markings that we made earlier. Once the dilator is in, the palm handle is going to come off the dilator. And his working channel, his cannula, we call it the access portal, is going to slide over. The access portal is 8mm inside, 10mm outside. It has its own little tapered tip to help it be nice and smooth as you pass the nerve root. Once that's in position, he's going to pull the dilator back out. And that access portal is going to serve as our working channel for the remainder of our discectomy instruments. So there you see a good shot of the portal there. First instrument through is going to be an 8mm drill. Basically just a big Archimedes screw, nothing too complicated. Spinning clockwise, this is going to drill out his initial cavity, and usually it actually pulls out a pretty decent amount of disc material itself. Once he's done that, he has an expandable instrument called the disc shaper. This does two things. It goes into that cavity created by the drill. He's going to pull back and expand it in situ. This is going to give us a larger space to work with for the remainder of our instruments, and because it has some annotations on it, he'll actually use it to measure the height of the disc, the height between the two end plates. And he's going to use that to size his cage. Looks like grabbing some material with a long pituitary now. Simple instrument, just an extra long pituitary made to fit through the portal. Break up some of those, pull out some of those disc chunks that we've broken up with our previous instruments. And this looks like it was a pretty quick one. Now he's going in with the articular rake. So this is basically just a square edge that we use for our end plate preparation. So he's going to go in both directions, up and down, scratch that cartilage off of and decorticate the superior and inferior end plates to help initiate fusion. Looks like now he's just packing in his biologic. So he simply had a tube loaded with those bone marrow soaked tricalcium phosphate strips. Plunge that into the space. Looks like he must have gotten sufficient resistance because he's happy with it. Now he's put the wire through to save the trajectory. That's important for a cannulated cage. He pulled the access portal out. And now he's actually going in with the cage itself. So the cage itself is it's a bullet cage. It's got its own self-dilating tip. And I'm guessing he's going to go for midline position on this case. However, you kind of have control as the surgeon where you want your cage to go, especially once you reach this point. Roughly about now, maybe one or two more hammers in, you can pull the wire out. And you'll still have some control if you want to drop your hand and go more horizontal, or if you want to raise your hand to go a little more vertical, go a little more anterior. I've seen people favor all kinds of different final cage positions for different reasons. In something like a deformity case, and here you go, Dr. Abbasi, pretty good midline position. Looks like he's going to tap it a little bit further, screw it off, and we'll come out. In something like a deformity case, a scoliosis, where one side's obviously much higher than the other, he'll try and position the cage eccentric to one side, kind of like jacking up the low side of the foundation of a house. Some people will favor a more anterior position to try and create more lordosis. I've seen some people say they prefer a more posterior position because they think it opens the foramen more. Kind of a dealer's choice. I mean, what's the old adage? You talk to 5 spine surgeons, you'll get 7 opinions, right? And there we go. Cage is in. I don't know if he's decided to do the level above yet. I guess we'll just see wait to see what he does. But it looks like he's getting ready to place the other side of pedicle screw wires now. Same idea. The AP is a little grainy. It can be hard to see the pedicles. Probably more trained eyes than mine in this chat here. But again, trying to pass the medial border of the pedicle around the same time he enters the vertebral body in the lateral. Nothing too crazy about this pedicle screw technique. Again, just to reiterate, if anybody has any questions, I ask that you keep your mic muted and utilize the chat feature. I will answer all of the questions I can. Otherwise, if we have any questions I cannot answer, Dr. Abbasi can join afterwards and address them. She's got the spine on the other. It looks like we're going to go in for the final wire. Still don't know if we're going to do the level above. I asked Dr. Abbasi, said it just kind of depends on the bone quality and some different things once he actually gets in there. If he doesn't decide to do the level above, then all we have to do after this is place our cannulated perk screws, connect them with rods, cinch them with set screws, and then we'll be done. One instrument I'm hoping we get a good set of x-rays to show is something Dr. Abbasi calls the facet decorticator. So it's actually an eccentric instrument that he uses. So in this instance, we're doing T11, T12. Using the wires from T12, you can actually use this eccentric instrument to center an instrument he calls the decorticator with some sharp teeth for decorticating the facets. You can use the wire below to center on the facets above, grind them, pack them with graft, and achieve his posterolateral fusion. If you read any of Dr. Abazi's early papers, he defines this pretty well. And he has some data and some photos on the posterolateral fusion rate as well as the inner body. Yeah, so it looks like we're just doing the one level. You can see now he's using the dilator, just dilating the tissue, dilating the fascia, to help his other instruments pass easier and hopefully help save the patient a little bit of post-op pain. Once he's finished dilating all four screw incisions, then I'll hopefully have a chance to explain that L-shaped decorticator instrument to you. Perfect. So there he is grabbing it. There's two inserts for this. One of them has a dilating tip, and one of them is a flat tamp tip. You'll see he goes down with the dilating tip. Yep, and he's going to give us some X-rays. Perfect. So using the wire below, he's able to center on the facet above. Then he'll drop it down, grind it with those sharp teeth. You can see his assistant's already packing it with that same biologic, tricalcium phosphate bone marrow soaked product we were using earlier. Then he grabs the flat end, the tamp, pushes it into the facets, and we're done. Usually takes him 20 to 30 seconds to screw. You're going to see it from start to finish again here. He goes in with the dilating tip, drops it down, grinds it on that hard surface of the facet. His assistant packs it with graft while he grabs the tamp. The tamp forces it into those newly decorticated facets, and it's out. And that's Dr. Abazi's method of achieving a posterolateral fusion. Perfect. Now we're going in with our cannulated screws. Nothing too crazy about this technique. We've been doing it this way for decades. Once his trajectory is more or less fixed, you'll see him pull out the guide wire. Maybe if the bone's hard, you'll go ahead and switch over to the T-handle. But it looks like it won't be necessary. The assistant will spin off that driver while he goes and starts the next one. Again, I want to thank everyone for joining. These are always a pleasure for me. If you have any questions, I ask that you use the chat feature. I will address them as best I can. If there's something I am unable to answer, Dr. Avansi will join afterwards and address those. We got our third pedicle screw coming in now. Alyssa, as tech, will go ahead and spin that out. Once she's got the towers free on the right side, she's going to grab that stim probe, go down and contact the head of the actual bone screw itself, and she'll start stimulating. Screws, Dr. Abbasi stimulates up to 25 milliamps. Though, of course, based on his own understanding of the screw position, he might accept lower. For anyone familiar with stimulating open screws, you might go to something like 8 milliamps. Dr. Abbasi's actually been trying to find a way to correlate the stimulation values for the perk screws to the open screws. Obviously, with the open screws, you get far less dissipation of energy because you don't have this tall tower that's contacting the patient's tissue in the posterior column there. And I believe he's working on a paper if he hasn't published it already. If it is published, I'll send a link. If not, I'm sure he will share it with the Avicenna Society group once it's published. But it looks like we've probably stimmed all our screws now. Dr. Abbasi grabbed the caliper. We measured for our rod. Now we're going to end up passing the MIS bullet tip rod. Again, nothing too crazy.
आप बताइए और आप बताइए
Like Dr. Abbasi is going to the back table to load the rod. Okay, it took a little longer than usual. It looks like we must have the rod loaded now. Dr. Abbas is going to start cranial or superior to the screws with the rod. He's going to poke the rod under the fascia, turn it horizontal, and then guide it through the two tulips of the screws. You can kind of see it in the lateral view there. But obviously, as you can see, because it's a thoracic case, he has the rod flipped upside down or bent to be kyphotic. Because obviously in the thoracic spine, we have to deal with kyphosis, not the same lordosis we do in the lumbar. So I'm guessing what was happening at the back table there was actually bending it the opposite way. Because the rods usually come pre-bent to be lordotic, not kyphotic. Simple enough. Once he's happy with the rod position, he'll screw in his first set screws, detach the inserter, finish off the set screws, and we'll be done. Again, Dr. Abbasi has been doing this procedure for quite some time now. He's done a little over 24 of them, obviously much rarer than the lumbar cases. Currently working on writing a paper for this, actually. I don't know if you can still see it in some of the views, but his PA Dominic is standing in the corner. Dr. Dominic, he's a good egg. There's a lot of helps Dr. Abbasi with a lot of his research efforts and is currently working on helping him draft that paper. That'll surely be shared with the Avicenna Society group once it's finished and published. So it looks like Dr. Abbasi at the back table. He must be bending that second rod again. Dr. Abbasi, with the rod bent to his satisfaction, is now back in place to maneuver the rod to its final position. Same idea. I'm starting superior. Ooh, looks like maybe he's actually starting inferior with these ones. Makes enough sense. In the thoracic. Passing the rod through, first poking it under the fascia, then passing the rod through the tulips for the screws, seating it down with the initial set screws, finishing off with the remaining set screws. He'll have a torque handle he uses to confirm that he's applied sufficient torque to the set screw itself. And actually, because Dr. Abbasi trusts himself more than any instrument, he'll actually grab a standard T-handle and test the screws himself just to make sure, using his own muscle memory, he's satisfied with how tight the screws are. Set screws are. We had a couple people just joined. I asked that you keep your microphone muted. If you have any questions, please utilize the chat feature. I will address them if I am able. Otherwise, Dr. Abbasi will have an opportunity to join after and address them. Perfect. I just got a question about the indications for this procedure. I do have an MRI up. I think that would be a good topic for Dr. Abbasi to join afterwards once he's scrubbed out and speak about. There goes Dr. Abbasi with his torque handle, putting his final tightening on the set screws. Once he's done with that, again, because he trusts himself more than any instrument, you'll see him put that static T-handle on and just using his own muscle memory, testing how tight the set screws are. Making sure they're satisfactory. Perfect. Now he'll simply cut the connection between the two towers, or the two tabs on these screw towers. Breaking with the two instruments his assistant has in hand. Pull them out, and then we'll close. For this procedure, since they're just small percutaneous incisions, Dr. Abbasi will just close all with tool Vicryl and some steri strips over the top.
Okay.
Perfect. I believe what Dr. Abbasi is doing here is injecting his Exparel. Exparel is a very expensive but wonderful medication. It is a long-lasting, basically liposomal bupivacaine. So where, if you give 0.75 marcaine, maybe gives the patient 24 hours, this usually gives the patient 3, 4, 5 days. Wonderful medication. He's seen a quite different result in patients post-op pain, giving the Exparel versus, more generic or cheaper medication. And we might have missed it, blinking you'll miss it. He usually has a 3 cc syringe mixed, I think it's 40 milligrams of Kenalog, and then he mixes in 1 cc of 0.25 marcaine. He'll use that around the incision site, just injecting it into the paraspinal muscle, just to help manage any post-op swelling. Sometimes you can get some post-op swelling, and it'll actually look like actually add some radicular symptoms for a few weeks. So he adds the steroid injection just to help keep swelling down, avoid that problem. Dr. Bassi here, just grabbing his finals. Perfect. Looks like he's got them. Now we'll finish his closing with his 2 O's. I don't think I spoke on medication. For this one, Dr. Abbasi for his local will use a mixture of 1-to-1, it's 0.25% marcaine, and then it's lidocaine, 1% would that be. Use that for his local, and then at the end of the procedure, he uses the Exparel that I talked about. Usually that is 10 cc's of Exparel mixed with 10 cc's of either saline or marcaine. I've seen him use both, depending on the patient indication. And usually a Kenalog injection. He used to do a full ESI, but he's found that it's usually simpler and less risky just to put it in this paraspinal muscle. And achieves the same thing. Just helps with any post-op swelling, keeps it from swelling around the nerve root, and creating some short-term radicular symptoms. Now, thank you all for joining. I will have Dr. Abbasi join afterwards and discuss his indications for this procedure, since that's beyond something I can comment on. If you have any more questions, I am happy to address them in the chat feature. If I cannot answer them myself, Dr. Abbasi will have a chance to speak on them when he joins. And if you have any questions, I'm happy to answer them, no matter how small. I love to continue narrating this, but watching some people suture up with 2 vicryls isn't particularly exciting. I think I've covered most of the things in procedure, but of course I have the burden of knowledge, I guess. If there's some question you have that's not immediately obvious and you want to ask it, please. The brand of liposomal. I believe the brand name is Exparel. It is unfortunately quite expensive here in the United States. I have heard about some other companies that have started to make an alternative. Yeah, Exparel. I'll put it in the chat. Exparel. It is a very good, but unfortunately very expensive medication. The patient seems to do incredibly well with it post-op. Again, seen days of relief for something like a 0.75 marcaine, where he'll use it some facilities that don't want to pay for the Exparel. They might only get 24 hours of pain relief before needing additional intervention. The perioperative pain management protocols that Dr. Abbasi has are something he probably prides himself on just as much as the technique itself. It's something he's been working on for the last 13, 14 years that he's been doing this procedure. And he's a big believer that the perioperative pain management has just as much to do with patient outcomes as the surgical technique itself. Perfect. Looks like we finished with our 2 O's. He'll slap some steri strips over that. And then once he is finished with those, he'll simply throw some 4x4s, maybe an ABD over the top. We'll pull the drape and he'll tape over that. This case, Dr. Abbasi is doing in a surgery center. I'm sure he'd be happy to give an update in the Avicenna Society WhatsApp group, maybe LinkedIn as well. Once he's done, I anticipate this patient will be going home 3 to 4 hours from now. So Dr. Abbasi should be scrubbing out and undraping shortly. I'm assuming Dr. Abbasi is going to help flip the patient onto the bed, but after that, he should be coming right over to discuss with us, answer any more questions you guys might add. And I know we had a question about indications that he'll be sure to address. Alrighty. Drape's coming down. Just for privacy reasons for the patient, I'm going to go ahead and stop that video. Again, if you guys have any questions, please let me know. I'd be happy to address them myself, or otherwise when Dr. Abbasi joins to discuss indications for this case, as I scroll through the MRI here, he can answer any other questions you might have. We just had a couple new folks join. So we actually did finish the procedure. Dr. Abbasi performed a T11 to T12 MIS OTIF, OTIF, oblique thoracic interbody fusion. The patient's being positioned, being flipped off the operating table into their patient bed right now. As soon as they're done, Dr. Abbasi is going to come in and speak a little bit about this case, as well as, most importantly, the indications he had for this procedure. If you have any questions, I ask that you keep your microphone muted just so we can keep the airways clear. Take your question and please post it in the chat feature. I will address any questions that I am able to. Otherwise, Dr. Abbasi will be joining us shortly, and he can speak on them himself. And this is the case Dr. Abbasi is performing at his own surgery center. I anticipate this patient will be going home in 3 to 4 hours. I will ask him to post an update in the Avicenna group once the patient is finished. Assuming the patient gives their consent, which I hope they would, given they were willing to let us videotape this procedure today. And that's another good question too. That one, since Dr. Abbasi is joining so quickly, instead of me giving a butchered answer of it, I will let Dr. Abbasi discuss the anatomical differences between obviously the thoracic and the lumbar approaches. So we'll discuss indications of this procedure, and we will discuss the anatomical differences. Barzan, I'm hoping that I'm pronouncing that correctly. I appreciate your questions. I really do. Helps keeping the active and collaborative, which I appreciate. I could probably sit here and talk all day, but nobody came here to listen to me. They came to hopefully learn some things about this procedure and get the words from the man himself, Dr. Abbasi. I've got word he should be on his way out of the OR, so it should be any time now. He may stop and look at his first patient of the day. Before this case, Dr. Abbasi did a pretty standard degenerative disc C5 to C7 ACDF. You might check on that patient before he joins us, but that shouldn't take too long.
Hello there. Not sure if there are any questions for me. No?
We just had one more person join. First off, I just ask that you keep your microphone muted so we can keep the airways clear. If you have any questions, please utilize the chat feature. Dr. Abbasi finished this case maybe 5 or 10 minutes ago. He performed a T11 to T12 MIS OTIF. They're currently flipping the patient from the operating table onto the patient bed. Once they're finished with that, Dr. Abbasi should be joining us to discuss his indications for this procedure as well as the anatomical considerations for doing this approach, thoracic versus lumbar.
Well, the same actually thoracic disc degeneration, and usually we confirm it with discogram. Are you able to hear me, Mitch? Mitch, are you able to hear me? Hello?
Yes, sir, I'm able to hear you, but I don't think Mitch is able to.
Oh, okay. I see. So as long as the rest of the team are able to hear me, it's echoing.
But I don't think Mitch is able to.
Yeah, we can hear you now. Sorry, Dr. Abbasi.
So, okay, well, I think it's echoing. You should. Okay, I think it's better. I had remoted into that computer. So, are you able to hear me now? Hello?
Yes, sir, we are.
Okay, so the indication is practically thoracic disc herniation, degenerative disc disease, foraminal and lateral recess stenosis, that when the axial pain is worse than radiculopathy part. The practically same indication that I have for the lumbar spine with a different. In the thoracic spine, I always confirm that as well with the discogram, that we add another layer of the diagnostic to that. It has just shown that for the thoracic axial pain has been very successful, this procedure. Now, if there is significant calcification and spinal canal stenosis, probably this is not the best procedure. So if there are any other questions, I'm happy to answer. And this is mostly for the technical procedure. Is very similar to OLIF, except that the entry to the skin is not at halfway through AP and lateral midpoint, but it's more close to the AP midpoint. So practically, if you draw a line from the lateral view to the AP view, mid portion of the disc, it's about 2/3 from the lateral and 1/3 from medial, because you have to overcome the rib, and so it's a more steep of an angle, and as well that you are always have to be above the same number to rib. You can actually right the rib, get to the head of the rib, and then you fall in. And this is a true transcambine approach, whereas we published actually many years ago a paper about direct thoracic, which is a transpleural approach. Obviously, the advantage there is that you can put the cage more horizontally. Disadvantage is that you have probably about 10 to 15% rate of pneumothorax, which is not a big deal. It's open. You put a pigtail or something, a chest tube in. But here, the chance of having pneumothorax is extremely low because, again, you are most of the approach is above the rib until you get to the head of the rib, and then you fall in the cambium triangle. Every single disc needs its own skin incision. Contrary to lumbar OLIF, where by moving the approach up and down, I put easily 3-4 spacers through one skin incision. Here, more or less, you need a separate skin incision for every single disc. Okay, if there are any questions, I'm happy to answer. Otherwise, we can call it.
Those seem to be the questions that we had, Dr. Abbasi. It was mostly about the indications for the procedure and then your considerations for the thoracic versus lumbar.
Dr. Fatih is talking about that. Yes, there was a previous fusion, and that is the interesting part. We did a discogram. It seems that the level just above the fusion wasn't really the pain generator. The 2 level above it was the pain generator. That is why we just fixed that one. Even though, usually I don't like to keep the standing level between 2 fusion, but in the thoracic, we are more generous regarding, the mobility is less. So it is more likely that that level doesn't need any attention in the future. Okay.
Okay,
We are going
thank
to
you.
publish
That
a
was,
paper about this very soon.
yes, it will be very much insightful. Actually, you have answered my 2 next questions because you have skipped probably a level, and I also wanted to know which disc was creating problems. So you already did some discography before the procedure.
This is a protocol routine for thoracic. Now, many times in the lumbar spine, I perform discogram to rule out, like somebody comes with 4 bad discs. Instead of doing 4-level fusion, we do a discogram. Often we see that maybe 2 of them or maybe 1 of them is more symptomatic. So we use the discogram not to diagnose it, but as well to rule out that we are not necessarily doing more surgery. And so, and the discogram as well, what's done today is very different than the discogram that was done 20, 30, 40 years ago. They look at many different parameters. We don't only use the morphology, we use the opening pressure, the compliance of the disc, like how much contrast do you put in the disc before you achieve certain pressure and so on. And that tells you how competent the disc is. And as well, now obviously the concordance of the pain that is generated is a huge factor. And here, most of the problem could be identified in that 11, 12 level. And that's what we decided to do.
Thank you.
You're
I got
welcome.
it.
Okay, well, thank you very much, everybody, for joining us. Hopefully we meet you soon. Please don't forget, not this Saturday, but the next Saturday, which is, I think, April 5th, we have our case conference. Please join us there as well. Thank you.
Okay, we'll join. Thank you.